Good morning, everybody. It is really great to see you. I'm sorry. It's like a typical morning on Capitol Hill when everybody has dealing with snow and ice, and they decided to adjourn a day early, and everything's being crammed into the same 3 hours. But you guys are taking the time to really learn, and I want to thank you for that. And I really want to thank Bill, who I love, who has done so much for prevent cancer, for lessening cancer. He's also healthier than I ever am. He does his bicycle rides. I'd probably last, I'm not going to say how long I'd last because I probably wouldn't even make that. But Bill really cares, and it's great that he does this every year. And it's really great to join Less Cancer, which has been a pioneer in cancer prevention long before prevention was understood or embraced or people really talked about it. It was the very first to say clearly that if we want to reduce cancer, we have to focus not just on treatment, but on prevention, on education, on the environment, access, and the conditions that shape health long before a diagnosis. Thus, he's healthy. You do. You really walk your talk. My office has been proud to work alongside Less Cancer in a bipartisan way through the Congressional Cancer Prevention Caucus and the National Cancer Prevention Workshop. As we have in the past, Representative John James and I are introducing or have introduced the resolution to honor February 4th as the National Cancer Prevention Day and recognize the importance of educating the public about the best practices for cancer prevention. And here's, for more than a decade, it's hard to believe we've been working that long on this, but these efforts have brought scientists, clinicians, journalists, advocates, and the policymakers, and the patients, and Democrats, and Republicans, and independents. Cancer doesn't say, oh, you're a Republican, I'm not going to get you, or you're a Democrat, it's ruthless, and it attacks everybody, because cancer doesn't ask who you voted for. It affects families in every community, in every zip code, and in every state. I've spent my life fighting for it, and you're going to learn about cancer today, but I also think everybody in this country should be able to go to the doctor when they need to go to the doctor and get the medicine that they need. And too many people, I meet them. Women won't go get a mammogram because they're afraid what happens if they do get it. And they won't be able to afford to get the treatment that they need. I know men who have prostate cancer, who again won't get the tests that they need. I mean, in both instances, people are afraid of what it means for their bodies, for their sex life, but they're also afraid they can't afford the treatment or they won't get and that's not right. So I just believe we got to help people try to prevent cancer. And if you get cancer, you should be able to go to the doctor. Education's healthcare, early detection is healthcare, and ensuring that providers have the latest evidence-based information is essential if we want to save lives and reduce costs for families and taxpayers alike. So that's why I'm especially grateful to Michigan State University for providing continuing medical education credits today. How many of you are from Michigan State?
Not everybody here, but online they are.
Oh, hi, online. And this is how we make sure science doesn't stay siloed. It gets into the clinics, the hospitals, the community centers, where it actually changes outcomes. You know, I'll look at all of you and tell you, I'm not old, but I am seasoned. And breast cancer has been one of the issues I've really started working on early. And it's not been that long ago, okay? You didn't say the word breast. I worked for General Motors. General Motors covered pills for men, I'll say it that way, but didn't cover mammograms for women. And, you know, it's we got to make sure that we are talking about it. We're not afraid that we talk about all parts of it. So I just really want to say that. I'm proud to see so many leaders connected to our home state of Michigan here today. Will be part of it. Dr. Mona, who everybody knows, Dr. Tricia Petzold, and journalist Miles O'Brien, who I think is joining from the Antarctica, right? And a reminder that science, truth, truth, facts, and prevention extend far beyond our borders. This is a time of transition in our country and in our healthcare system. Too many people aren't going to have access to it. And in moments like this, progress doesn't come from rhetoric. It comes from persistence. It comes from organizations like Less Cancer that keep showing up year after year, doing the work, building the partnerships, and insisting that prevention matters. So I really want to thank Bill, the Less Cancer, all of you for caring enough to be here. And I hope you have a great day, that you learn a lot, and you become an advocate, because it's everybody, you're not old, you're seasoned. Like, you guys are young. You can make a difference. So thank you. I'm going to get in trouble here. It's been a long week. Thank you.
Thank you very much. Super great. If I can introduce Tricia. Tricia is our chairman of Less Cancer, chairwoman of Less Cancer, and physician in Utah. She's been trained as an ER physician and has her own practice. But Tricia, I want you to tell us, I'm going to move to the podium, tell us a little bit about what you do, and let's hear a little more about that.
So I'm a family and emergency medicine by training and practice for 18 to 20 years. And now I do more integrative health and wellness and teach that at the medical school. So I'm thrilled to see, and now I can see the room. I'm thrilled to see all the students. Thanks for being here. And one of the questions Bill asked me was why prevention belongs in everyday clinical care. And as emergency physicians are trained to act fast, stabilize chaos, and save lives in the moment. We aim at being experts in the now. But the truth is, many emergencies that we treat, even cancer-related complications, are downstream consequences of risks that were visible years earlier. Cancer prevention belongs in everyday clinical care because every patient encounter is a leverage point, even brief ones, even in the emergency department. And I'd like to mention 5 reasons why clinical prevention belongs in everyday clinical care. First, cancer doesn't start in oncology, just as heart attacks don't start in cardiology. They start in everyday life. Most cancers and chronic diseases are not random events. They're driven by modifiable risks: tobacco, alcohol, physical inactivity, UV exposure, environmental toxins, delayed screenings. By the time cancer becomes an emergency, such as a bowel obstruction, a spinal cord compression, or a massive GI bleed, we've lost the opportunity to prevent it. We're left with disaster control or damage control. And emergency medicine is at a unique crossroads where prevention is really needed. We see patients who rarely access primary care. We care for high-risk populations, and we witness consequences from missed prevention more than almost anyone else. Second, prevention doesn't require long visits. It requires intentional moments. There's a myth I hear from many physicians that prevention needs time we don't have. In reality, prevention looks like one sentence, one question, one referral, one nudge at the right moment. For example, a smoker with chest pain is more open to discussing cessation today than during a routine visit. A patient who has repeated alcohol-related injuries may be ready to hear about cancer risk. And young patients with severe sunburn is receptive to skin cancer prevention right now. These are teachable moments. In the emergency department, we encounter those daily. Prevention doesn't slow us down. It amplifies the impact of the care we're already delivering. And third, I think prevention is part of the job of every physician in any clinic, in any hospital emergency department. By normalizing prevention as part of emergency care, we shape the department culture, we influence our trainees and students, and we signal to health systems that prevention is everybody's responsibility. When it's done well, there'll be embedding of brief prevention prompts in discharge paperwork. They'll be partnering with oncology, with primary care, with public health, and they'll be supporting protocols of tobacco cessation, of HPV vaccinations, of screening follow-ups. And modeling language makes prevention feel routine, not optional. So culture changes with these little interventions. Fourth, prevention is an equity issue. Cancer disproportionately affects patients with limited access to primary care, low health literacy, and structural barriers for screening and early detection. These are the same patients who rely on emergency department as their main point of contact with the healthcare system. So if prevention doesn't happen in everyday clinical care, including the emergency care, often it doesn't happen at all. Uh, Integrating prevention is one of the most powerful ways we can reduce cancer disparities without waiting for the system-wide healthcare reform. And lastly, physician burnout prevention. Disease prevention aligns with why most of us went into medicine. We didn't choose this field to react to diseases. We chose it to reduce suffering. Every prevented cancer is one fewer emergency, one fewer ICU admission, and one fewer family devastated by a diagnosis that arrived too late. When prevention becomes part of everyday clinical care, emergency medicine stops being only a safety net and becomes part of the solution upstream. So, in closing, prevention belongs in everyday clinical care because although we may not follow patients for years, the words we say, the systems we shape, the priorities we model can change the trajectory of their lives. And sometimes the most life-saving interventions isn't what we do in the resuscitation bay, but what we prevent from ever bringing a patient there. Prevention isn't in competition with acute care, it completes it. And it is with huge gratitude that I'm here with you, learning and celebrating and supporting the ongoing efforts of Less Cancer. I'd like to just thank you all for being here and participating today.
So what some of you don't know is that Tricia teaches a class on food as medicine. Is that correct?
Correct. It's called culinary medicine.
Yeah, and you're teaching it to up-and-coming physicians? Who are you teaching it to?
Yeah, it's fabulous. It's a multidiscipline class. I teach it with a dietitian, and we teach it to dietitians, upcoming medical students, pharmacy school students, advanced nurse practitioner students, and social workers and health coaches. So it's a real great.
Tricia did a workshop this year in Traverse City, Michigan that was very powerful with not only demonstrations, but lots of great stories about the intersection of food and medicine and what that does for our health and how our lives improve with it. But I'm just wondering if you could give us a couple examples of what all this means, all this word spiffing mean. Like, tell us a little bit about the mission of the class and what that looks like. And
a lot of what we learn in medical school is the biochemistry of food, which doesn't apply very well to when you sit in front of a patient who has trouble accessing food, doesn't know how to cut a tomato, who is scared of or doesn't have the finances, or they live in a food desert, or and when the physician doesn't realize or hasn't been taught how to talk to patients in that setting, then the power of the food is lost. And each person eats each day, and it's one of the most powerful biochemical changes in our body every day. And so to understand how to take the complex science knowledge that the dietitian knows and that we can access and be able to apply it in real life experiences, whether a patient comes in and their children are eating all processed food. There's knowing how to cut oranges and bring them to the soccer field instead of something, a big package boxes of things they pick up at a convenience store, and getting the kids involved, helping the kids pick out and prepare some of the vegetables as the family's cooking for dinner. And then talking about what really the impact is of food on slowing down and reversing diabetes or cardiovascular disease, how to feed someone who's suffering from kidney disease, and how to bring it into a clinic and talk about it even when you have 15, 20 minutes, how to prioritize, how to build group visits, how to build group education within your own clinic, or reach out to the community and work and teach in community centers. So really being creative and thinking outside the box a bit, and starting with the science of how food is medicine, and then using motivational interviewing, other behavior change support, and it's really multi-dimensional from dietitians to physicians to psychologists that really make the shift in creating an environment where wherever people show up as, they can heal, they can reverse their disease, they can slow down their disease, they can thrive.
And so much. I want to tell you, I don't know if you can tell, Tricia, but we have some young students here that we're proud to have from Warrenton, Virginia, in the Highland School. And, when we're talking about things like slicing a tomato, peeling an orange, whatever it may be, I think a lot of times we assume, like, are you kidding? Like, because our world is so different from a lot of the world. Places that we might not know, or places we might not see, where things like access are different, where people don't really understand where some produce comes from, or how it's growing, or what the story is behind it. And Tricia really helps with that education process. And I hear from a lot of people, and there are people that don't really understand the difference between something that might be fresh and something that doesn't come out of a bag in the freezer, or out of a can, or out of a fast food store. They don't understand that there are options out there. And it isn't necessarily, I want to be clear, it's not necessarily a choice for everybody. People do what they can with what they have within the scope of what they can do. And so, early on, more than 2 decades ago, longer than any of you have been alive, I used to not understand that myself, because I came from a place where I just assumed everybody understood these things. Well, in very fast order, I learned that was not the case. And I'm wondering if you could express a little bit more about access and some of those issues.
Yeah, we have one of our sessions. We cook out of the pantry on campus. There's food insecurity right here in the medical school among our medical students, and certainly among our city. And so there's a variety of pantries, and we will do recipes out of the pantry to help people understand what the options are at different
Just to interrupt
parts
for
of it.
a sec, food insecurity, if you can just explain a little bit about what food insecurity means, like not knowing where your next meal is coming from. If you just to expand on that for a second. Sorry to
Yeah. Thanks, Bill. Yeah, the not knowing where your food's coming, your next meal is coming, and it often shows up in making decisions about what books these students are buying, and how many times in a week they're eating some very plain noodles just to get calories in, which isn't as nutrient. A lot of families will not be balancing their nutrient density, for example, which we're teaching as well in the course. So really knowing where the options are and what the access is, and how we teach it is we teach the students to explore their own nutrition through these different venues and these different avenues, and then learn to teach it to their patients, and then look for opportunities to look for collaborating with resources, the Utah Food Bank, the Wasatch Community Gardens, nonprofits in the community that then can come together and support their patients or their community where their clinic is, to do some education, do some outreach, and provide baskets of food to help with those type things.
Do we have any tips on what we can do to make prevention in general more accessible for everyone?
Yeah, I think it needs to be more front and center in our medical systems. And cultural shifts need to happen from the medical side. And I think where it really, I've seen the needle move the most is when there is collaboration with community outreach, housing projects, community gardens going into housing projects, in establishing a garden for residents to come out and learn about food and be outside accessing it. And so I think that it has to be discussed more and empower people in the communities, in these nonprofits, in these areas, to be aware and to have discussions and to have an access point. In our city, we have the community health centers and we have free clinics, but it has to be more of an honored part of our medical system. Move away from just identifying diseases to realizing how to really allow people to be healthy and thrive is to catch things early and provide opportunities for access for screenings and immunizations.
I think, one thing that we're discovering through our work at Less Cancer and through the work of Tricia is that we're getting better at pivoting. We're better at figuring out. We understand things that, is different for everybody. We don't blame anybody, but people have different sets of circumstances. And it's not a flip of a switch for most people. And so is there anything you'd like to add to that, Tricia?
Thanks, Bill. Yeah, I think the model of Less Cancer and realizing the impact it has when the emergency rooms are safety nets in a lot of communities, and for the staff, the nurses, the aides, the physicians to be aware of prevention in their treatment is another space that a lot of underserved and with people with less access are reaching. And so I think this message is important, and it's important from a medical space to have prevention in the places you least expect it in medicine.
Our next speaker is Chris Moore, who is a Less Cancer board member, also our treasurer, and he's a super bright guy. He's makes sure our wheels stay on the ground. He's also with the UN Foundation, and he's here today to talk about his bigger message on health. And Chris, I'm not going to say much more, but if you could take it away and tell us a little bit about what you're doing at the UN Foundation.
Thank you so much, Bill, and great to be here. Thank you all for being part of this very important program and the work that Less Cancer is doing. I joined the board, I guess, 2 or 3 years ago, and really couldn't be more impressed by the work that this organization is doing across the country and the impact that they're having far beyond. So much effort on cancer is focused on treatment, and that's a critical area. But if we can prevent and keep people from getting this terrible disease in the first place, that's where we want to spend our time. As Bill mentioned, I'm with the United Nations Foundation. We are a U.S. charitable organization that was founded a little over 25 years ago by a guy named Ted Turner, who you might remember as the founder of CNN. And at the time, he was trying to give $1 billion to the United Nations which was the amount that the U.S. owed to the organization at the time. And to enable that gift, he created the foundation to be a conduit for those resources. Over the years, we have spent a lot of time and effort championing America's role globally and the work that the United States can do in the world, but also causes that are important to all of humanity, including in the area of global health, where I spend my time. I lead our global health advocacy team at the UN Foundation, and we run different public affairs campaigns that support efforts to combat malaria, to ensure that children are vaccinated against diseases like polio and measles around the world. I'm not a scientist, but I spend a lot of my time on Capitol Hill right here, working to educate members of Congress, their staffs, the general public about the importance of America's investment in global health and our work to eradicate infectious diseases like polio and malaria. We're working to make sure that the U.S., in partnership with other countries, is able to detect disease outbreaks quickly, to eliminate those outbreaks, and that protects Americans here at home from diseases around the world. We're succeeding against pretty stiff odds and rapidly evolving diseases. The world has eradicated smallpox that used to be a huge killer. We're very close to eradicating polio. Just 2 countries in the world have wild polio today, so we're almost there. Over the last few decades, we have eliminated malaria from nearly 4 dozen countries. These infectious diseases, like polio and malaria, are continuing and evolving threat. Diseases mutate, they respond to efforts to prevent them, so it's ongoing work. Infectious diseases are pretty scary. And some of them pretty terrifying. For example, Ebola. You've all heard of this. This is a disease that breaks down the cells of blood vessels, and essentially people who are dying of this disease, their organs liquefy, they bleed out, and there are other pretty terrible sounding infectious and parasitic diseases too. Brain-eating amoebas, different types of worms, vector-borne diseases spread by mosquitoes and sandflies. All of this very much the stuff of nightmares. And you can see how important it is for us to finish the job with diseases like malaria and polio. But if you ask Americans the diseases that terrify them the most, as pollsters have done regularly over the years, you won't really hear about infectious diseases like polio or malaria. You'll hear more about what we call non-communicable diseases, or NCDs, like cancer. Cancer always tops the list of the diseases that Americans care most about and are most worried about. Heart disease, Alzheimer's, up there as well. Over the years, those non-communicable diseases have come to replace infectious diseases as the biggest killers in just about every part of the world. Today, about 2/3 of global mortality is due to NCDs. That's about 18 million lives, people dying prematurely every year because of those diseases. The burden of cancer in particular has risen pretty sharply. And by 2050, there are projections by the World Health Organization that cancer will claim over 35 million new cases, a 22% increase from just a couple of years ago. And so this remains a very serious and growing threat. How did some of this transition happen? Why are we now facing a bigger burden of NCDs rather than infectious diseases? In the last century, in the early 1970s, an American epidemiologist named Abdel Omran came up with what he called his theory of epidemiological transition. And essentially that meant that there are changing population patterns, mortality, other factors that account for this replacement of NCDs for infectious disease deaths. Basically, the global community has gotten a lot better at preventing infectious disease infection through immunization, through improved sanitation, better health care, other measures. Today we have vaccinations, we have bed nets to help control diseases like malaria. None of that is an accident. Lots of people have worked very hard to put those prevention measures in place. But the upshot is that more of us, many more, are surviving to adulthood and into later life, and our disease burden has shifted with us. So our mortality, our deaths are now increasingly related to diseases like cancer, cardiovascular disease, and others that are due to some degree to human behavior patterns. For example, smoking, alcohol use, our diets. The Global Burden of Disease Study, which was started by the World Bank in 1990 and is now published every couple years, has really tracked this trend, finding that communicable causes of death generally have fallen around the world, and we're now seeing much more non-communicable diseases. The shift is pretty uneven. So in wealthier countries, you see a bigger burden of non-communicable diseases. In poorer countries, infectious diseases continue to be a big part of the burden, but we're moving in the NCD direction globally. The world has, as a result, united to address the challenge of NCDs. The United Nations hosted a landmark meeting on NCD prevention and control in 2011. Now, in the Sustainable Development Goals, NCDs is a part of that, and specifically addressed there. Last September, world leaders considered a new political declaration on NCDs and mental health. This was a breakthrough. The global community rallying around cancer and other diseases and how to address them. The declaration addresses cancer pretty broadly, so it's not just traditional areas, but also oral health, childhood cancer, rare diseases, and so pretty comprehensive. And that declaration proposed targets for reduction and control of risk factors, including tobacco use, hypertension. It sets also ambitious process targets, including access to medicines, healthcare, and health technologies around the world. So what can be done? So a lot can give us hope on cancer today, and you'll hear about this, I'm sure, from others speaking throughout the day. There are really incredible advances in cancer treatment now. If you are a cancer patient today, there are many more opportunities to address those diseases than ever before. Those include inhibitors, targeted therapies, protein degradation strategies, epigenetic drugs, new tactics to overcome resistance for traditional cancer drugs. AI tools are evolving very quickly to speed the drug discovery process, but also to improve targeting. And these tools even offer the tantalizing possibility of solving death itself. And I'm speaking of cell death and how precisely we target and destroy damaged cells and maintain and extend the life of healthy cells. Fascinating opportunities and work there. But to me, and really to Less Cancer's mission, some of the most exciting new developments on the cancer front have to do with prevention, including AI-powered cancer detection, imaging analysis, predictive risk models, how we get better at detecting cancer early, and are able to address it. Things like liquid biopsies, cancer early detection tests that are showing incredible promise. New tests for the early detection of pancreatic cancer, a huge killer, 85% effective now. That's a huge breakthrough. Now we can see this disease coming and stop it before it gains strength. There's genomic profiling now, cancer biomarker driven diagnostics. So the testing, the imaging, the ability to look ahead has been very powerful. New vaccines are also coming into this picture as well to prevent cancers and diseases that can lead to cancer. You probably are familiar with the HPV vaccine. There are also vaccines related to hepatitis B, for example, that are helping to reduce liver cancer risks. Personalized RNA vaccines. So a lot of incredible research and opportunities for promotion. So just a few things that I wanted to share, Bill, on the NCDs, the way the world is rallying to address them, but also some things that should give us hope moving forward.
Well, we're so grateful for your work. Couple questions. We have some younger members here today in our audience, and I wanted to drive home the fact that when we work to prevent cancer or lower risk for cancers, we in turn do so for a multitude of diseases. And so that, everything has got, and Tricia, is Tricia still on here? If you have, Tricia, if you have any comment on that, I was just saying how when we work to lower the risk of cancer, it works across the board. And some of the work that the UN Foundation is doing is incredibly powerful. And not all of it's here at home, but when it's even around the globe, it helps people here at home a lot. And more than we can really understand in a snapshot. Some of these issues are a little more complex than like flipping a switch up or down or putting a vaccine or getting a Band-Aid. There are lots of issues behind these. Is there anything you'd like to add to that, Dr. Petzold?
I want to say thank you to Chris for that wonderful overview and really did highlight how interconnected we are as a world. And so I agree with you, Chris, that the work that Less Cancer is doing across the nation is even greater. And just as we export a lot of our nutrition technology that is not always health focused, we also the science we do for prevention, immunizations, and all the incredible future potentials that you just listed clearly impacts way beyond our nation. So thank you. That was fabulous.
You're doing great work, Chris. We're so grateful to have you be part of the Less Cancer Board and grateful you're here today. Does anybody have a question for Chris? It's okay. We can pick this up later too. What I'd like to do is see if we could start with Caleb Runyon, and we have an opening PSA that we're going to play here, and we're going to tell you a little bit about Caleb's story after the PSA.
Hi, I'm Yvette Bowser, the creator of Living Single and a member of the board of Less Cancer. As we all know, some of the people we trust the most work in personal care. You're our hairstylists, our nail technicians, our barbers, people we see on the regular and are super comfortable with. And while you're not healthcare providers, you are often the first to notice if someone's skin looks different. And here's the thing. People with black and brown skin do get skin cancer. It's just unfortunately often detected later because it's harder to see. A dark streak under a nail, a foot sore that doesn't heal, a patch of skin that keeps changing color. So if you see something, gently say something and encourage your clients to get it checked out because you never know. You might be the reason someone catches something early. You might be the reason someone gets to live a longer, healthier life.
She's a great board member of ours. She's a spectacular human, and we're so grateful to have her be part of of our work with less cancer as well. So we played that PSA because our next speaker is a nurse practitioner by the name of Caleb Runyon. And Caleb, I met through my daughter, and he has started a project that I'm incredibly impressed with, and I want you to learn about it. And he's going to talk about it. We've done a couple of workshops called When You See Something, Say Something, that speaks to this issue in the workshops that we did with people in the personal care business that might do hair, which I don't know about, or, nails or massage or tattoos, or anybody that works with you on your personal care. So Caleb, can you take it away? Tell everybody here about yourself and what you do. And
Sure. Good morning, everyone. So, as Bill said, my name is Caleb Runyon. I am an acute care and dermatology nurse practitioner. And I started the Closer Look project because in our practice, seeing dermatologic patients, every single day, probably one or two patients a day would say, "Oh, my hairdresser noticed this spot. What do you think about it?" And I assess it, I do a biopsy, and 9 times out of 10, it was skin cancer. And so I remember thinking, this is a very unique perspective from hairdressers, and that's kind of where it landed me. I didn't do much with it. I just continued to work. Well, in February of 2025, my grandpa was diagnosed with melanoma, stage 4, meaning that it's metastasized to internal organs. And at that point, I felt kind of ashamed, right? My grandpa has cancer, and it's a cancer that I treat every day. So why was this missed? And it's not something that, you can blame yourself for. These things happen. But I started to think about how could we have prevented this from happening. My grandpa is 77 from Logan, West Virginia, and he does not go to the doctor often. He actually hates going to the doctor's office, but he gets a haircut every 2 to 4 weeks, which how many of you guys go to the doctor once a month? How many of you go to the hair salon once a month? Yeah. Just one of you. Okay, great.
I think
they all do too.
The looks.
Exactly. And so I started to realize that hairdressers have a unique advantage in helping someone decide or realize that something is wrong. And there are lots of old men and old women and regular aged women and men that go to get their hair done monthly and never go to the doctor's office. And there are several reasons as to why, and we'll get into that a bit later. But so I started this initiative, the Closer Look Project, so that we could educate hairdressers and barbers on signs of skin cancer. And from that point, what do they do, right? Like, no, this looks like melanoma. This looks like a skin cancer like squamous cell carcinoma. What do you do with the information? Not much, right? Unless you're connected with a dermatology provider. And so I took it a step further and decided maybe we should see if hairdressers and personal care professionals, which include massage therapists, nail techs, tattoo artists, estheticians, makeup artists, whoever that gets up close and personal, what if they could actually refer their client to a dermatology provider or just a regular provider? And so we now have 7 partners across the East Coast and 1 on the West Coast that will accept referrals from hairdressers and tattoo artists and massage therapists. And it's really shaped the way that people get skin cancer evaluated and treated. And so that is the Closer Look Project.
Caleb came to Warrenton, and we did a workshop in the First Baptist Church on Alexandria Pike, historic Virginia church, to discuss these very issues. And we did a demonstration on somebody that, if it's okay, Caleb, we'd like to play it right now for our studio audience.
I always start out with a view that kind of just takes a look at my client's face and seeing anything that I, straight away, what is concerning to me. And so, I'm not trying to diagnose him today. If there's something suspicious, I'll likely talk to him afterwards. But looking at the face from a whole, perspective, that kind of gives us a micro assessment. And then we know where to zoom in on. Okay, so typically I'll start from the side and kind of work my way around. And so which areas would be the most concerning for men especially? Well, I would say the ears, behind the ears, and the scalp. A lot of us are thinning up top, myself included. And so I forget oftentimes to put sunscreen there, and I'm sure that you do as well. And so that is an area that the sun has direct view of all day long that you're outside, or if you're driving or whatever. So that's an area to be mindful of. Behind the ears and in the ears, in that conchal bowl region, that's another area that's concerning. So I typically will start on the side here and just take a quick look. Now, you see, most of us have these kind of like lines here. Laugh lines, smile lines, wrinkles, whatever you want to call them. You always want to kind of take a little bit of a deeper look there. Good. Great. So, this region here is getting so much sun exposure, right? So just something to be mindful of. And if you have a wide part, if you have blonde hair, if you're bald, these are things to consider, because sunscreen, you probably aren't putting it there, right? Who thinks about that on their head?
And Caleb, what are you looking for? Certain
Yes. So
what do you
I'm looking for anything that's different from his skin tone. So, he has an even skin tone here, but if you see something that's darker, for example, here's a little maybe ingrown hair or something there that's a little darker. I don't know if you can appreciate that on the screen, but if you start to see something that's discolored, if it's ulcerating, if it's bleeding, if it's itchy, those are abnormal signs, right? How many of us have itchy spots all the time? You shouldn't, by the way. So those are areas that you should probably check in on. So that's what I'm looking for. Any indiscrepancies with the skin tone there? Good question.
And when do you do this kind of exam, Caleb?
So with these exams, I typically will start, like in clinic, we do these once every 6 months, once every year. For hairdressers, I think it was someone mentioned that your wife goes to the hairdresser twice a month, right? And for a lot of women, my mom included, do not touch my hair, do not touch my scalp. But her hairdresser's got her hands all in there, and she's very happy to have that. And so, what a better time to take notice. And you don't have to even be, you don't have to announce, oh, I'm parting the scalp and parting the hair and looking at this scalp. I'm looking at this spot. I'm looking behind the ear. Just be mindful and just kind of just take inventory of what you're seeing. So what you just saw is basically the education that comes with hairdressers and massage therapists and tattoo artists who do the training that we offer. And so it kind of goes into depth about skin anatomy and what's abnormal and when should you refer and how can you refer them to a provider. So it's a really unique program that we've started. And as hairdressers become a part of the program, our team will actively start to search for clinics that will accept referrals from them in their regions. So if you have a hairdresser or a nail tech or whatever that you'd like to be involved with, you can send them our way.
Great job, Caleb. We're super grateful. We're going to come back to Caleb, but we're going to take a 1-minute break. We want to say goodbye to Chris Moore, who is going to be on his way to save the world. So thank you, Chris, very much for joining us. So next up is one of Less Cancer's superhero to the planet as well. Hey, Rob, we have people on Zoom and people in the room and people that will be streaming this later. Can you tell us a little bit about your story and then what's new with it today?
Sure. Well, thanks again. Thanks, Bill. It's a real pleasure to be here with everybody today and help support this amazing work that Less Cancer's been involved in for so long in trying to deal with prevention of cancer. And, today you're hearing me, a lawyer, talking to you. You're probably wondering, why are we listening to lawyers here talk about cancer prevention? And I'm going to tell you about a matter I've been dealing with a group of chemicals called PFAS, forever chemicals. And this story really highlights how prevention of cancer sometimes requires you to go back a couple steps. A lot of times we're talking about making sure we're getting the right tests and getting to the right doctors to make sure we're addressing something we know might be a cancer-causing agent. But what I've been dealing with for, several decades now is a situation where information about the existence of chemicals that were out there that could cause cancer, that were coursing through the blood of virtually every person on the planet and in everybody's drinking water, but nobody knew about it. And the scientific community didn't even understand these chemicals were out there. The lawmakers and regulators didn't know. So we really, it involved lawyers and lawsuits to try to get this information out to the world so that we could start taking the steps necessary to actually stop the cancers from happening. And what I'm talking about here, again, involve this group of chemicals called PFAS. These are chemicals that never existed on planet Earth prior to around the time of World War II. But at that point, they were created by some chemical companies that then, once these chemicals were created, they started pumping them out into all kinds of different products that were used all over the place. Anything that was nonstick, waterproof, stain-resistant, grease-resistant. So things like nonstick cookware, fast food wrappers and packaging, clothing, carpeting, dental floss, computer chips, firefighting foams, all these different products. And unfortunately, what we now know is that these chemicals, the companies that were making them, started doing studies and tests way back in the 1960s and the 1970s, even before a lot of our laws in the United States governing how you test chemicals to make sure they're not causing cancer, even before a lot of those rules existed. Well, the companies creating these chemicals found out that these things could cause cancer. In particular, even testicular cancer and kidney cancers. But unfortunately, that information wasn't shared with the scientific community. It wasn't shared with the government, with the regulators. And it wasn't until some cows started dying on a farm in West Virginia in the 1990s, and we were asked to try to help figure out why these cows were dying. Well, that led to a lawsuit where we got access to all kinds of internal documents where we first discovered that these chemicals were not only out there in the water these cows were drinking, but were potentially all over the country, all over the world, in drinking water, in air, in soil, in food, in the blood of all of us. And importantly, that although the companies had been doing science and had found out these things could cause cancer, that information wasn't shared with the rest of the scientific community. It wasn't being published. So doctors didn't know about it. The lawmakers didn't know about it. There were no rules or regulations on these chemicals. So we had to then spend years. We're now, I think, in our third decade of lawsuits and litigation to force this information out into the public. And I think, fortunately, what we've seen is the power of getting that information out, bringing that information to the scientific community. We ended up setting up massive studies with tens of thousands of people, the communities that were exposed, incredible evidence-based science, that was able to confirm the same thing these companies had known for years, that exposure to these chemicals could cause cancer. And then work for years to try to bring that information out to scientists globally so that they could understand the threat, to the medical community, and most importantly then to lawmakers and people who could actually start taking steps to regulate these chemicals and restrict them going into the world. And that took a long time. It took us actually sitting down and figuring out how do we spread this message? How do we alert people that they may be exposed to these things that could cause cancer? And that led to, as Bill mentioned, things like the films, Dark Waters, documentaries like The Devil We Know, a book, Exposure. All of that helped engage and educate the public so that people who had been exposed to these chemicals for decades and decades finally became aware And that awareness then triggered people standing up, speaking out, saying, hey, we shouldn't be exposed to these chemicals. We should be regulating them. We should be restricting them. And that public awareness and the scientific community and doctors becoming aware finally led to lawmakers being able to understand the problem. Now we have the first federal laws in this country stopping those exposures from drinking water. We have them being declared human carcinogens by the top federal agency in the United States. We have global organizations like the UN and the EU now taking steps to ban these chemicals, and companies that were making and using them are phasing them out. So I think this is a great story, and particularly for young folks who want to know, like, how can I get engaged and how can I help things like this? You know, you don't necessarily have to be a scientist or a doctor. You could be a lawyer. You could be a filmmaker. You could be somebody that helps storytelling. There are so many different ways to help bring awareness of cancer-causing materials like this to the public, and importantly, generate change. We are seeing steps now being taken worldwide to prevent these exposures going forward. And even companies that are now trying to invent ways to figure out, how do we get this out of people's blood? How do we reduce those exposures going forward? So I think, a really, it can be a little overwhelming when you hear this story and hear about these chemicals that are everywhere and in everyone, and think, gee, what can one person do, and how can we ever stop this? I think if you look at this story, it shows how much you can do, how much even one person speaking out can change and help prevent cancer exposure for millions of people across the planet. So thank you, Bill, for the opportunity to be here today. And I'm so delighted to see all the young folks there in the room, because you're the ones who are going to help us fix all this and make sure that we don't do these kinds of things again, we don't have these kinds of issues. So thanks a lot, Bill.
Thank you. I want to say, when we talk about ordinary people doing things that can actually move the needle, I first learned about Rob in the New York Times. I don't know. Well, how long ago was that? 15 years ago? 12 years ago?
It was exactly a decade ago, Bill. January of
a while ago, I read the story about him saying he was DuPont's worst nightmare. And I was like, oh, this guy could be my friend. And sure enough, he is. And from that, he joined the Less Cancer Board. But also, it was about that time we created the House Caucus on Cancer Prevention. And Rob was really the very first person to speak at that House Caucus on cancer prevention. Never before. Like, I'm a C student. I'm no whiz kid. And we created this, initiated this caucus. Rob spoke at it. And since that time, since a decade ago, there have been not just awareness, but laws that have actually, and policies that have protected the public from these chemicals. It's pretty amazing. That's a lot how public health works. Public health works on information, on science, on evidence, and policies that help to protect people. And so people might say, oh, I don't need protection, I can do it myself. But the reality is, we need policies in place to help. It's like keeping up the roads or doing any number of things that we do to help keep our communities safe and healthy. And so, Rob, thank you so much. Does anybody have a question for Rob while we're here? Just shout it out or talk to me. Anybody?
No, Mindi has one.
Mindi Messmer. Can we flash the screen on her? Thanks, Jan.
Rob, Rob, we all owe you such a debt of gratitude. I can't even say you're one of my heroes. And the amount of work that you've put in over the last 30 years is incredible. Where do you see the future of your work in terms of where's the next emerging threat? What can we do to solve, get ahead of those next emerging threats? Where can we go to, look at more of the 15,000 chemicals that are part of the PFAS umbrella? I just wanted to see what you thought for the future, what this holds for us.
Thanks so much, Mindy, and it was great to see you. And again, I appreciate all you're doing as well in the public health field. There's plenty to still be doing in PFAS. Most of what I've spent the last 30 years doing was focused on two of the chemicals in the PFAS group, PFOA and PFOS, and those are the ones that we're finally beginning to regulate and finally beginning to phase out of all these products. Well, unfortunately, as we phased those two out, we found out there could be 15,000 related chemicals that are maybe just one carbon or two carbons different from these other chemicals. And we're being told, oh well, you need all this science and evidence before we can regulate these others. And there's an incredible need to address how do we go about regulating chemicals in this country and frankly internationally as well, and how much is enough evidence and enough science to begin protecting people. There's a real concern that in the United States we have historically required so much absolute proof that a chemical is causing harm, is causing cancers, before we can actually regulate and begin to address it. Whereas in Europe, for example, they tend to take what we call a more precautionary approach, where that steps are taken to try to prevent the cancers from happening before they begin. But in our country, unfortunately, the way our legal system and our regulatory system has tended to be set up, we unfortunately have really required a lot more before we can move it into the category of being regulated. And we've seen that with the PFAS chemicals that we have finally begun regulating. So I think this whole issue with PFAS has really, I think, begun the discussion, which we've needed for a long time, about how do we make sure that we're enabled to start taking steps to prevent harm before the harm happens, versus requiring people to spend decades proving that harm has actually happened first. So to me, that's where I see a lot of the future fight going.
I hate to interrupt on this, but I wanted to, because we have a speaker coming up that's right after you. I hope you can stick around, Rob, because for a little bit anyway, because I think we're going to have more questions, and we're going to be hearing from Dr. Mindi Messmer again, whose all books you have. But we wanted to jump over to Hanna, who is coming to us from Flint, Michigan. Can we pull up? Thank you so much, Rob. There she is. And look what I got here. I don't know if you can see what I'm holding up, but this is her project that is spectacular, and we're going to hear more about it. But Dr. Hanna, some of you may know, is the hero in the Flint water crisis. Some of you may have read about her in Time magazine when she was on the cover. I mean, she's done incredible things as a pediatrician. And speaking up, she has been an inspiration to my own daughter, who is going to be a pediatrician very soon. And we are so grateful to have her here today. So welcome, Dr. Mona.
Hey, Bill. Hey, everybody. Thank you for having me. And it's so wonderful to be here with some of my heroes and colleagues and fellow fighters in the environmental health world. So thank you for all the incredible things that you do. I could talk about lead, I could talk about water, I could talk about the precautionary principle and all these things that you all heard about, but I'm going to talk to you about something a little different. And that is about a new program that we are starting to really get upstream to improve health, especially of children and families and really entire communities. So as Bill mentioned, I was kind of the whistleblower that helped expose the Flint water crisis. And since then have really been working on recovery, making sure that the kids of Flint had the brightest future possible, but also trying to make sure that we do better to protect kids, be it with stronger environmental regulations, the Infrastructure Act to replace lead pipes, which is truly primary prevention, or all these other things that we need to do so that we don't keep reacting to crises, which is often what we do in the public health world. So we, in the decades since kind of that uncovering, a lot of my work has been to put into place really proactive, evidence-based, child-centric, prevention-driven interventions, especially in Flint, and really to be able to share those best practices. And we've done great things, from like expanded early childhood and nutrition support services and trauma-informed care and mental health and Medicaid expansion, and the list goes on, a registry supported by the CDC, all these great things to support families. Yet we continue to hear from families, and we continue to see in our big data how hard it is for families to get by. And we know that like economic instability, poverty is kind of this root cause pathogen that that makes people sick. It increases the risk for environmental exposures. It increases the risk for all kinds of disease, be it developmental delays, chronic diseases, failure to thrive, childhood obesity. And as a pediatrician who has been practicing in a poor place, be it Flint or Detroit, for a long time, it's been frustrating not to be able to prescribe away poverty. And I used to shrug my shoulders like, I can't do anything about this. And then something amazing happened in DC in 2021. We, during COVID, we did something about it. We became like poor countries, and we expanded the child tax credit. And that pretty much gave most families with children unconditional monthly cash allowances. And we became like 70% of countries in the world that do child allowances. And we dropped child poverty to the lowest level ever recorded in U.S. history. Millions of kids went out of poverty, and we saw all these tremendous outcomes improve. And so that became a proof point, like, oh my gosh, like we can do big, hard things in this country. We don't have to be okay with kids growing up in poverty. And that was incredible to see as a pediatrician who with a public health background, who's been trying to address upstream things for a long time. And then unfortunately, that was not renewed in the U.S. Senate by one vote. One vote, and millions of kids went back into poverty, and those outcomes reversed. So for me, it felt like it was really important to keep this work in the public imagination, to be able to continue to inform policy. So that's what inspired RX Kids. We call it a prescription for health, hope, and opportunity. It is the nation's first universal and unconditional mom and baby cash prescription program. So what does that mean? It means every pregnant person in a community gets $1,500 in mid-pregnancy, and every baby gets $500 a month for either 6 months or 12 months. It's focused on moms and babies because that is the most economically vulnerable window of life. That is when families are poorest because income drops, expenses rise, we have no paid leave, all these reasons why this is the time that is the most economically insecure. But as many of you all know out there, this is also the most consequential window of life. What happens in this brief window can really shape your whole life course. Baby's brain doubles in size in that first year of life. So our goal is really, we should be surrounding moms and babies, especially with this kind of nutrient-rich environment, especially in that brief window, to protect them. So it's a time-limited program to support moms and babies. It started in Flint, Michigan, where I'm at 2 years ago. And it has now spread to 28 Michigan communities. We have prescribed over $20 million to over 5,000 families. Next week, it launches in the city of Detroit, which is just ginormous. There's 8,000 babies born in the city. And there's a lot of excitement to do this in other places in the country. There's legislation in Hawaii, Mississippi, Oregon, Washington State, lots of interest elsewhere, and lots of bipartisan interest. So this is a really efficient program. It's really time-bound. It's a tiny program. It's pro-family. It's pro-child. It's pro-life. It's pro-baby. It's parents' rights. It's, all these different things that really resonate with so many kind of different kinds of folks. But ultimately, it's about prevention, right? It is 100% about prevention. And I will kind of and we have tons of outcomes on our website. We've been able to improve family financial stability, a 90% drop in evictions, housing stability, diaper security, less back-owed rent, improvements in maternal mental health, less stress, less depression, postpartum depression, less anxiety, population level improvements in birth outcomes, less premature babies, less low birth weight babies, less NICU admissions, increase in prenatal care. So massive, massive population level improvements that have been stubborn to move. move, and we're finally moving them with this really simple intervention. Families don't need more parenting classes or, bureaucratic stigmatizing programs. They just need to not be poor, and they know what's kind of best and how to take care of themselves. So lots of amazing outcomes, and you can learn. Our website has tons of information, just arcskids.org, and I know you guys have some materials on hand to learn more about the program. But I will end with, the theme of ARCS Kids is love. We have a heart in our logo. And fundamentally for me, this is about how we're supposed to love, especially our children. And so a lot of our work really is around narrative and communication and marketing, which I think has been a lesson for me from dealing with the Flint water crisis to kind of writing a book about it. It's the storytelling work. And how important that is to kind of really shape public opinion and inform policy. So as much as we are eliminating poverty and improving kind of health, we're also trying to reimagine that social contract, fundamentally how we can care for each other in a very prevention-driven way that treats families with dignity and trust and agency. I guess I will end with my favorite quote, which kind of drives me as a pediatrician and very much drives this program, and also drives why so much of our programming is around Valentine's Day. So we have lots of exciting stuff on Valentine's Day, and is historically it's about loving our mamas, but it's also a tribute to Frederick Douglass, who gave himself the birthday of Valentine's Day, and has said, and this is my favorite quote, "It is easier to build strong children than to repair broken men." So much of what we do in the world of prevention and environmental health and this program is about, once again, working hard to build strong children rather than reactively doing too little, too late to repair broken men. So, Bill, I'll stop talking. I have to run to another meeting. I love you.
We love you, and we're
Thank
so
you for
grateful.
having me.
We're so grateful for you, and we continue to wave your flag. We're so honored you could join us today, and thanks for all you do. Your work is truly heroic.
Thank you.
So
Good to see everybody.
Thank you. So this is the problem when you have people who are literally saving the world. They got to rush in, rush out, but we are so grateful to have her today. She is really a superhero. Dr. Graham Colditz from WashU, who did the nurses study, once told me that he believes cancer prevention starts when kids are little. How we eat, where we live, can we eat, what we're doing. So it's these very basic things are so critical in mapping out healthier futures. We have Dr. Jan Carney. Can we pull, is she on right now? She is. Dr. Carney, hey, welcome to Washington, D.C., and to our Zoom audience and to our streamers who will be watching this later. But Dr. Carney has been a board member for several years, is a public health leader, is a physician, a spectacular educator. I have sat in on her classes, and I'd like to welcome you today. She's from the Larned College of Medicine at the University of Vermont, and was hoping you, Dr. Carney, could tell us a little bit about what you're doing and what you did with us this year with Less Cancer.
Absolutely. Thank you so much. I'm really happy to be here. You know how much I love students, and we love students. And Less Cancer has been a partner in our community-initiated public health projects, which is part of our medical curriculum here. That makes us it's kind of unusual. It's a requirement in the curriculum. So our community organizations submit project ideas, and then the students figure out how to do it and then give the results back. And it's supposed to be very practical and public health and prevention oriented science. So this year's project, we've done a lot with Less Cancer. And what we've been talking about here is the idea that we really need to think about preventing cancer at a younger age. What does that mean? And most of the risk factors are the habits that we have and adopt, and particularly through, teenage, young adult, all through your life. How much you exercise is really important. the quality of your diet and what different foods you eat and you don't eat, alcohol use, and we've learned a lot more about the research there, tobacco use, of course, stress, sleep, and whether you use sunscreen. Those are some examples. So we had a medical student group of 8, and we sort of gave them this challenge. Let's figure out what are some of these areas and that's really important, and how do we increase consciousness among young people about preventing cancer? Because that's really when you need to adopt some of these great habits that help protect you throughout your life. So students did that, and they came up with all these very creative posters and infographics. And, then they decided what they would do is they would go out to UVM and places where college-age students were, and they'd try them out. So they'd see how effective they were. They had a QR code, they had a quiz, and they kind of tried out. They put them up as posters, and they did like alcohol and physical activity, nutrition. They were all very, very creative and colorful. They tried putting some of them out on social media. And then they tried having them like as a poster and a conversation. So to engage people in a conversation about preventing cancer. And not surprisingly, they got a great response. So medical students and students talking to other students and young adults is really the best. They got a lot of people talk to them and responded to their survey. And not surprisingly, they found out when you have a conversation with someone, that really improves the impact. That's the best way. And Bill sort of said that when he started and wondered if that was really true. And that was his impression, and it really is. So we're worried right now about all the not so scientific information that people are getting from social media and public websites. And I think what the students learn is it's really important to take that science and have conversations with people. Now, these are medical students, so that's something that will resonate with them as they're seeing patients, and they see patients in the office or the hospital or clinic somewhere. But it's also really important from our own educator perspective. When we put out public information about evidence-based science to prevent cancer, we have to make sure that we have a way to have conversations, whether one-on-one or what I call community conversations. So I think we learned a lot. And Bill, just so you know, the other organizations, and we had 16 total projects this fall, and they were all awesome. The other organizations are asking for the posters and the infographics so that they can share with their own audiences. So that's to me, that's great.
It's really great. And you are great at reaching people. Dr. Carney's written several books on public health and has the greatest understanding of these things. And so one thing that you're seeing here today is that we are always partnered with the experts. We are always partnered with those that don't have a feeling, but actually have the training and actually have the experience and operate under the umbrella of evidence-based science. That's what guides us. That's how we know these things. And so this isn't a shoot from the hip experience. And we're so grateful to Dr. Carney for her leadership and your leadership with Less Cancer. And I've learned a ton from her classes as well and from her students. And we always have a great experience, and we're super grateful for your leadership. So thank you for being here today.
You're welcome.
Super grateful. We are, thanks so much. Please stay on if you can. And we are going to now talk to, is Miles on? Oh my God, this guy. Hey. Look where he is, you guys.
Now, brown cow, can you hear me?
Yeah, look at that. Look at that. And that is not like a pull down shade behind him. Just FYI.
No, this is not green screen. This is not. This is not AI. This is a beautiful summer day.
Isn't that amazing?
In Antarctica. You're looking at the Thwaites Glacier behind me, the one they call the Doomsday Glacier. I'm sitting up on top of a Korean icebreaker filled with scientists who've been down here for, we left New Zealand December 27th to study it every which way they can. And, I've been thinking about cancer and climate and those connections. And, the knee bone is connected to the thigh bone. And when you talk about climate and you talk about greenhouse gases, often a separate discussion, which shouldn't be, is that burning fossil fuels creates a tremendous health problem for air in the form of air pollution. And you think about all the cancer alleys with the production of petroleum products and the refining and the extraction, the amount of cancer associated with just getting those fossil fuels burned, which are in fact directly affecting this glacier behind me and causing it to melt at an alarming rate, is the first order of business. The second order of business is that the impacts of climate change are now becoming very real, whether it's hurricanes with more moisture in them, increased wildfires, or a little further down the road, this glacier behind me, there's nothing right now that's going to stop it from sliding into the sea. It, in and of itself, represents 2.5 feet of sea level rise all over the world. And it is a keystone glacier. It holds back 2 other ice shelves. The whole combination is in excess of 10 feet of sea level rise all over the world. So what does climate change mean to people in coastal communities? And what does this glacier mean? A lot. And it also, there is, of course, as we've been discussing here, an economic justice issue here. The rich people can build bunkers and seawalls or fly away in their corporate jets, leaving the disadvantaged behind to pay the consequences of it. And that includes all kinds of negative health outcomes. I was in New Orleans during Hurricane Katrina, and who were the people that were impacted by climate? It was the poor people, of course, and those impacts directly affect to rates of cancer. There's kind of a climate cancer cluster that isn't necessarily geographically on one part of the map, but really is kind of global. And so we're here and on a mission that is sponsored by the Korea Polar Research Institute. They have partnered with the British Antarctic Survey to come here, and the primary mission was to drill a small hole in the glacier down to the Amundsen Sea beneath, to put in some sensors, leave those sensors behind, and sort of create a weather station for Thwaites so that scientists could come up with an accurate forecast for when it might melt and whether that might be accelerating. Well, unfortunately, they were not successful in leaving those long-term instruments behind. The instruments actually got frozen into the hole they created on the way down. So that was a big setback for them. They got some instantaneous readings, though, which indicate that the water beneath Thwaites is about 5.5 degrees Fahrenheit above the freezing point of glacier ice. So we know what's happening. It's melting. It's melted. We don't know what kind of forecast to give because they need those long-term measurements. And this brings me to my point, which connects back to Bill and all the work you're doing. This is about science. Rob has seen what happens when corporate science is negligent and greedy, and people die as a result. Well, for years and years in this country, we have had a federally funded scientific enterprise that has gone a long way toward curing dread diseases and creating all kinds of innovations that make our lives better. It's been eviscerated in the past year or so. I am sitting on this vessel. There's not a single penny of federal U.S. research funding for these scientists. The Koreans have taken the lead on this. The U.S. has cut its polar program such that it doesn't even have an icebreaker anymore. And the U.S. has taken a back seat to the Koreans. And we should all thank the Koreans for taking this leadership role, because after all, this research helps the entire planet. But this idea that we can't solve any of our big problems if we don't at first define them and get the data and understand them is so crucial. And this small team tried to poke a tiny little hole in a glacier and didn't fully succeed. But it, to me, is a reminder that we need to redouble our efforts to try to understand what's going on here. I am a long way away from you, but it's very much connected to the tidal basin in Washington and what it's going to look like in the coming years. And that has direct impacts on disease and cancer outcomes all throughout our society. So if I could give you one message today, it's the value of federally funded basic scientific research that goes to places like this and tries to understand the problem so we can at least start thinking about some way of solving it, or at least some way of adapting to it. And I just want to say, as far as Less Cancer goes, Bill, as always, you do such a great job in focusing a discussion that you don't hear much elsewhere. I always talk with you about the corporate cancer machine. There is, frankly, no profit incentive in preventing cancer. And so there's not a lot of money out there right now to tell the story you've been trying to tell on a shoestring. And it's just like these scientists here on a shoestring. We have to keep fighting. We have to keep getting on the ships. We have to keep screaming from the tops of those ships the truth of what's happening. And I appreciate you and what you do fighting the good fight. So all of us here, you're all key members of that effort. And I'm glad we're all in this together, because our voices should count and hopefully will.
Well, we're so grateful for you, Miles, your leadership, not only with Less Cancer as our former chair, but also in the work that you do in telling the story of science, the importance of science, and saying it in a way where everybody understands it and can be part of it. And we are incredibly grateful for your work and the important work you're doing there now, and very proud of you. This is really such a treat. This year's cancer prevention workshop really has a focus on students and younger students. And as you know and have been part of, we have provided very small, but scholarships to nursing students. And we try to provide also these students here today with materials and information, evidence-based science, and the hope that they will be in charge of change going forward. So thank you so much for joining us today. And please thank your team. And we're really proud of you. We all are following you on Instagram and Substack, and your revelations are incredible. And it's been a real joy and an honor. So thank you very much for being here.
All right. Watch the PBS NewsHour tonight. We have one more story coming out tonight.
We will.
Little plug. But thank you for all your good work, all of you. And I would love to stay, but I'm getting a little cold right now.
Yeah, I know. I bet. Stay warm.
All right.
Take care.
Bye-bye.
Thanks for everything. That's pretty exciting. Wasn't that cool? How many people do you get to see live from Antarctica? Our next person up is Mindi Messmer. Is she Mindi Messmer, who is now Dr. Mindi Messmer? Each of you have a copy of her book that I'm providing you with today. Some of you in years past have had it, and it's a great book because I wrote the foreword. But anyway, it's a good book. And Mindi, we are so glad to have you here because, I first knew Mindi when she was a legislator. And prior to that, actually, even before you were a legislator, I think, when you identified cancer clusters, pediatric cancer clusters, which is almost impossible to get done or accomplished. It's such an impossibility. So I'm going to let you take it away, Mindi. Tell us a little bit about your past situation and your work currently going forward with AI and cancer prevention.
Well, hi, everyone. I'm so happy to be here with you today, even though I can't be there in person. I kind of feel like Miles. I could really commiserate with Miles because I'm coming to you from New Hampshire, which is my home state, which feels like it's almost as cold as where Miles is, but I'm sure it's not. And I've lived in New Hampshire as Bill said, identifying a pediatric cancer cluster, actually a double cancer cluster here in the community in which I live on the seacoast of New Hampshire, which actually made me run for office as a scientist, longtime scientist. Scientists aren't really known for doing that because we have a different sort of set of personality, I think, than most politicians you would think have. But really, it was important for me to get involved when I found this cancer cluster and decided that we really need to kind of unravel what was happening in our communities here on the Seacoast. And I want to shout out to Rob again, because he really spent some time 10 years ago with me after one of your Less Cancer meetings in the room there, just describing to me what he had seen in West Virginia. And that was actually what has come to be very helpful in terms of, my legislation in the State House was passed into law and really was one of the first states to regulate these chemicals really in an effective way, and has really raised that conversation at a very high level in our state. And also I've been working with Bill to continue to do that in DC. But I want to talk to you a little bit here today about AI. And I've just completed a doctoral degree in medical science with a focus on AI. And I really did that because although there's a lot of bad press around AI, I really am hopeful that these tools will be extremely helpful to us in the future in preventing cancer and other chronic diseases in our communities. As we heard from Rob, these PFAS chemicals in particular are linked to various kinds of cancers and other chronic illnesses like high cholesterol and preeclampsia, which is something that I'm sure Dr. Mona is familiar with. But when we're trying to develop those threads of evidence to say that there's a problem, there's an association, or much even better, a causative effect from something, that's very difficult to do in science. It takes a long time. And you heard Rob talk about the 3 decades that he was working on PFAS in the legal sense. And also he was working with scientists like me to start developing this scientific evidence and the legislative support. That takes a really long time. And what we found in particular in my state is that we're seeing those effects of those people being exposed to these chemicals for a long period of time through an Air Force base called Pease Air Force Base on the Seacoast, and from industrial air emissions from a company that does textile coating called St. Gobain Performance Plastics that moved from Jan's state of Vermont to New Hampshire, southern New Hampshire, and polluted southern New Hampshire's entire aquifer of southern New Hampshire. And now we're seeing very high rates of kidney cancer. And through the work of legislative committees that I serve on still in the state of New Hampshire, we were able to get the state to recognize this effect of kidney cancer and other cancers and chronic disease in our communities as being the highest, some of the highest in the nation, including pediatric cancer, which New Hampshire is the highest in the nation. And so what I think is that AI is really going to be the tool of the future to help us as scientists to analyze all those thousands of water samples, the blood sample tests that are done, all different kinds of data, so many pieces of data that we are really behind the curve in taking 30 years to look at them and understand how they're affecting our communities. I really think AI is going to help us with that. It can do things like what I do now in my current role as a healthcare. I work in the healthcare system, a big nonprofit in the Washington, D.C. area. And we're using AI to look at what the conversations are between clinicians and their patients. Are they talking about air pollution levels in being high? Are they talking about the wildfire smoke? Are they talking about concerns about water, lead in their water, or things like that? So I think those untapped sources of data that are very challenging to turn into something we can understand is where AI is going to help us to unravel those things and to much more quickly answer some of the questions that scientists have. We have the science. It is sort of like an AI research support tool for us to be able to understand and get our arms around this huge amounts of data, all different kinds of data, and package them into what we can identify as clusters of disease before they actually become these clusters. There's a lot of bad press around bias and privacy and things like that, and is it going to displace jobs? But I'm not talking about things that are going to do that, but I'm talking about things that support scientists in answering those questions. And it's very open work. It's not this, a lot of times AI is being used in some of these companies and it's very black box. We don't understand what it's doing. We don't understand why we're seeing these ads pop up, things like that. But in science, we're really working hard to document our procedures, be transparent about them, transparent about the algorithms that we use, so that it can be validated, it can be used by other scientists to understand better all of these public health concerns. And think about what Dr. Mona talked about a little bit and what she uncovered in Flint, Michigan, where officials hid the water contamination for a very long time with lead. And if we had an AI surveillance system going on then, we could maybe spot those issues of high levels of lead in the water system much earlier. And instead of being responsive to a public health threat, we could probably work toward preventing it. So we're working from treating cancer to preventing it. And a little bit of what Miles talked about is it's not really in, the public realm of being able to support us moving to that prevention, because they actually want to just treat it. And what Bill has always been talking about as well for a long time. But this is a way that we can actually move toward prevention, I think. And it really could have an impact in providing cleaner water, safer communities, and fewer sick kids. So we have a choice. We can use AI as a tool for profit and surveillance, or we can use it as a prevention tool for justice. And I really encourage the students in the room to start thinking about ways that you could use AI in your studies and in your, future educational pursuits, to really understand how we can use this tool to our benefit rather than being afraid of it from all the press that you've heard. And we can serve the public good. So thank you so much, Bill, for providing this opportunity for me to talk. Happy to answer any questions, but so happy to see so many joined today.
Next up, I think we have Monica Baskin. Is Monica up?
Yes, I'm here.
I hear her great voice. Are you calling me from somewhere far away, or are you?
Just a little ways down the road in Richmond, Virginia.
Okay, good. Well, Dr. Baskin is a wonderful person that we've worked with, first at the University of Pittsburgh, now she is with the Massey Cancer Center, and she has personally taught me a lot about some of the social issues around healthcare, some of the health disparities. She's a really important leader in our country on many of these issues, and she's also a board advisor to Less Cancer. We're super proud of our affiliation and her being here today. So thank you for being here. We mostly have students in this room today, and we were hoping maybe you could share a little bit about what you do, what you're doing, what you're looking to do, and take it away.
Yeah, thank you so much, Bill. I really appreciate the invitation and apologize for not being able to be there in person. It was funny as I was looking at Miles on the screen. Many of you might know in this region we had a severe kind of freezing rain event about a week or so ago. And just yesterday, my family and I were out chipping away at our driveway. And we commented that it looked like we could make an igloo, and it looked a lot like the background that Miles had there. But delighted to be here virtually with you all. And as Bill mentioned, I am a researcher by training. So I'm a psychologist in terms of my education and training, but I have focused on issues around cancer prevention and control research for more than a couple of decades. And a lot of that work has focused on communities that the Congresswoman opened us up talking about, communities that don't have the same level of access to prevention or treatment or survivorship. And so that's been the large part of what I've done. And what's also unique about the research that I do is we consider it, or we call it, community engaged research. And so what that means is that we're not just coming in doing things with populations. We are actively engaging communities that we want to work with as a part of our investigative team. They're helping us to think about what are the important research questions that are out there. What are the methods that we we should go about answering those questions and also interpreting those findings so that, sometimes inadvertently scientists might put out information that may actually do a little bit more harm than it does good. And so if we're always describing communities as we taught, heard about my other colleagues, in Flint, Michigan, or in West Virginia, other places, if we're only highlighting the things that are wrong and negative, that's doing a disservice to the community. It's doing a disservice to those wonderful folks that Caleb, for example, works with that are doing amazing things with limited resources. So that type of work where we're engaging communities is really important. And it's also important because we come up with all these different ideas, but they may not work for the community. So we want to make sure that our evidence base, the interventions, the programs, the strategies we're coming up with make sense for that group. So that's really been the focus of the work that I do more specifically. And as Bill mentioned, I've been in a couple of different locations. A large part of that work has been in rural areas in the Deep South, where individuals, again, are struggling with financial means of access, but also something, especially given the audience there today, we also have a shortage. We have a shortage of medical providers. So physicians, nurses, physician assistants, we have a general shortage of primary care providers. So you can imagine that there's an even greater shortage of specialty providers as well. So oncologists and radiation oncologists and other folks there. So in those communities, they don't have the access. So that's why I really, really enjoy the program that Caleb and team are doing by finding people in the local community that are the natural helpers. They're the people that you're going to go to anyway, and training them on things to just look out for so that you can, help encourage people to move along to that next step, to have it further evaluated. But that also means that we have to partner with our local organizations. So obviously, if you have a NCI designated cancer center like ours here in Richmond, that's fabulous. But if you have a local federally qualified health center, that is also important to make sure that we are making those connections from our community members to get to that clinical care. And sometimes that means that people need things like they need a ride. They need somebody to be there with them to help understand when you get that information from the provider, what does that mean? Or when you hear that word cancer, somebody else is there to hear what comes after that, because sometimes it's really scary to hear that information. And so I think those partnerships with local organizations, whether or not it's faith-based organizations or other groups that may help, like I said, with transportation or with food and nutrition, that's a lot of what I do, is making sure that we make those connections so that those social drivers of health are not disadvantaging people, so they're not able to get the quality care that they need to live a long life. But I know, since I'm the closing kind of panelist here, I also want to just leave this audience with more of a sense of excitement and hope. So one of the things that we do know over the last several years, the death rate for cancer has declined dramatically. And a large portion of why that has happened is because of things like what Less Cancer is promoting. So obviously issues around prevention, which include diet, physical activity, not smoking or limiting exposure to smoke, and also limiting exposure to these environmental toxins. Those things are fabulous. But another part of prevention is, as people on the panel have also talked about, vaccinations. So we know, for example, that HPV vaccination is a tremendous asset to prevent people from having multiple types of cancers later on. We also know that early detection is really critical for things like colorectal cancer, where when you have, a colonoscopy, for example, where you can go in and you can remove and eliminate any polyps before they grow into cancer. So that is another way of prevention. So you've got the primary methods of prevention, you don't have it. And then there's some secondary prevention as well, including, helping people to keep from having a recurrence of cancer. So there is a lot of excitement around the things that we've already learned in cancer prevention and research, about partnering with other community members. And we are certainly hopeful that we will continue to advance this work so that we have more people celebrating birthdays and anniversaries for many years to come.
Well, we love your work and we're such a fan of yours. And thank you for your leadership and all the heroics that you continue to do. We're very grateful for you. We're going to hear from Representative Don Beyer before we wrap up here. But I wanted to say that we all have an opportunity to use our voices. We all have and you may not know something specifically, or you might not be an expert, but don't ever let anybody talk you down from a concern or something that you really care about. I'm thinking of two people today that have been helpful in the work that we do, not necessarily specifically to us, but in our shared goals. And, you know, there's an influencer on Instagram by the name of Chris and Dave, and she has done extraordinary things with some of my issues on health access and did a video with me earlier in the year that made a crazy difference. I mean, had like 500,000 viewers and a gajillion likes, but it made such a difference because she used her power well and smartly to share a message. And then there are people like Katie Couric, who is a journalist who is first reported about her colonoscopy maybe 15 or 20 years ago, maybe longer, I guess, and, you know, is a screening advocate for especially breast cancer and a founder of Stand Up to Cancer. These people are pretty regular folks for the most part. And those that aren't are using their platforms smartly to ask for change. And we all have that opportunity to ask for change. We're all powerful. Everybody sitting here is powerful. And you can use your voice in such a transformative, smart way. And I'm so grateful that you guys are here. So before we wrap up, can we listen to Representative Beyer? Pull him up on the screen.
Hello, I'm Congressman Don Beyer, and I'm delighted to welcome you all to this year's National Cancer Prevention Day and the National Cancer Prevention Workshop here on Capitol Hill. And thank you to Less Cancer for putting this all together. I'm encouraged to learn that so many people are gathered here to make a real difference in cancer prevention. And we know what that difference will require. It depends on sound science, accessible screenings, and robust public education. It also depends on everyone having access to high quality, affordable healthcare. Science and education and Medicare all have to work together to reduce suffering and save lives. I appreciate the work that Less Cancer does to elevate this issue and keep science front and center. I'm committed, along with the rest of the bipartisan House Cancer Caucus, to putting Congress's support behind research, education, and prevention efforts. We cannot have a real national response to cancer without that. So thank you for the important work you're doing and for keeping that response a bipartisan priority.